It's a gamma. It's quite stiff. Так, эклипс наша вернулся. Ага. Все хорошо. Жень, как звук будет, скажите? Yes, Steve. Hello, dear colleagues. Almaty Presidential. My name is Mynzhylky Berdikhojayev. My assistant is Rawan Moratova. Eleman from Osh. Vishal from Kerala and Jaya Shankar from Kerala. Madina is our operating nurse. And Yevgeny on the video stream, and we have anesthesiology team. But this case, we decided to operate this patient, lady, 63 years old. She has chronic kidney disease with renal failure, and she's on chronic dialysis. That's why anesthesiologists asked to operate under local anesthesia without general, as it could be quite challenging for anesthesiology team. That's why, yes, when colleagues asks, we are doing in local. It's not problem for us. I think it's a left, sol жағындағы, да? Right ICA aneurysm, nearly 4 millimeter in PCOM segment, unruptured, just headaches, and because of chronic dialysis, heparin using, she's scared from possible complications from aneurysm, and we also recommend to operate this aneurysm. The guiding catheter is 8 French coronary Asahi Hyperion. We did just manual pre-shaping. I will show you how to do it. Okay, it was a little bit problem during the femoral artery puncture, some spasm because of the local anesthesia, and patient is scared from the aneurysm. Yes, I showed to Vishal and Jaya Shankar and Ilaman. We gave more than nearly 320 degree. It was completely like this, but finally it's a 70 degree. It's eclipse, it's a gamma 17. It's quite stiff microcatheter. And this was Judkins right, like this, and then we gave first shape like this, and the second shape we took like this. And finally, it's a multi-purpose MP catheter. You used to see it from different companies, but it's quite cheap. It's nearly $100 in our country, maybe less. And most of the procedures we are doing with this Hyperion guide catheter. It's a stable, and for the carotid artery stenting, for the multi-catheter techniques, it's possible to use. And because of Judkins right previously, it's also easy to navigate. Nothing is easy, but when you have experience, by the time it comes easier. Yeah? I couldn't say for the colleagues with 1 year experience it's easy, but maybe after 7,000 operations it's quite easy. Yeah? Yes. You should give time for your experience, and then you can save your time because of the experience. Okay, let's check the femoral artery. It was slight spasm. Yes, it's our protocol. It's a common femoral. Yes, we punctured common femoral. No spasm, everything is okay. I think I came from superficial femoral to the common femoral. Yes, might be small leak at the bifurcation with the deep femoral, but no problem. The control panel still not working. It was kaput. It stopped working couple of maybe 3 weeks ago, just after Neuradic meeting, and now it's also not working. And it's a little bit problematic when it's a strong part of Philips when you use this control panel and do measurement in the operating room. And now this machine became like a usual other brands, yes? You couldn't measure in the operating room, you need to go to the control room. Yes, okay. Okay. You can see the aneurysm. Aneurysm nearly 4 millimeter. Yes, patient took hemodialysis yesterday, and today, if everything is okay, maybe we will send this patient for the dialysis just after operation. But now, yes, our goal, yes, we are not limited from contrast amount. We can use how much is necessary, and patient on dialysis, and just after operation, or on Monday she will go to the dialysis, and we can take out from the blood circulation all contrast, no problem. Okay, so it's quite easy catheterization. With this kind of guiding, it's easier. It's not so easy when you start the neuro. Usually to go to the left carotid is all the time painful, but when you have multi-purpose catheter, usually it's okay, no problem. Okay, there is a slight stenosis, supraclinoid ICA. shake period. Yes, it looks like there is an infundibulum. It's on the AP. You can see there is a artery is coming. Okay, just a second. Let's check from the ICA territory. Yes, because of some deformation in here, the introducer sheath was influenced to the guiding, and now guiding is a little bit compressed. Yes, there is a arteries coming from the top. Stop. Okay. On lateral you can see. On lateral you can see there is an artery coming from the top of the enlargement, and it looks like yes, it's an infundibulum of internal carotid artery on PCOM segment. Okay, let's look like this. Yes, now you can see nicely. Stop, nozzle. Yes, this is infundibulum, and there is a ICA stenosis, but it's not the goal of this treatment. And patient has PCOM, patient has ACOM, and little bit hypoplastic A1, but it's not a problem. We'll follow this stenosis. It's not the goal of this treatment for today. Here is okay. Тия. Қай жан? Қол аяқсыз не болды? Оң жақ қол аяғы ма, сол жағы ма? Rowan is noticing it was TIA in summer and patient had weakness on right side. Okay. Okay. Let's measure the stenosis then. Maybe we need to treat this stenosis, huh? Okay, let's see. Okay, we prepared single lumen eclipse. It's a 615 balloon from Balt company. Бір тампон бересіз, важно. Тампон керек, может. 615 from Balt. It's coming with this Y connector. We just put 60% contrast, 6 contrast to 4 saline in 10 cc syringe. It's easy to measure. And then we took from there 3 cc of mixed contrast and connected with 3-wave stopcock and closed the Y connector, flushed with the 60% of contrast, and just put the wire, checked, and now the system is ready. And for coiling we took a gamma microcatheter, gamma 17. It's also Balt company, and today on the shelf we have only gamma microcatheter. Yes, it's a crazy healthcare system of our country. Yes, there is no choice. You couldn't have all together. Sometimes you have only headway, sometimes you have only gamma. Okay, we can use all of them with no problem. Okay, I will do maximum zoom. It should be not so complicated navigation. Let's pick one segment. Let's do angiography. Okay. Yes, the aneurysm with daughter sac. And the only moment it looks like anterior choroid artery is coming from the neck, huh? You see? And ICAs look like a little bit stenotic. Let's see, maybe now we need to do 3D angiography. Because of this point, nobody wants to occlude anterior choroid artery with coils. That's why we could change our strategy. Stop now. Okay, I think to be sure about the choroid artery, we need to do 3D angiography. Так, Роман Маратович, может, қойып келесінші 3D. 3D-ні қойып келесінші. Контраст қойып жіберсеңіздер. Ана жерде no деп жаба салу керек, жоғары жағы. Қойып қойдың ба? Қойып қойдың ба? Дәулет Шекович бар ма? Ассалаумағалейкум, Дәулет Шекович. Yes, and unfortunately, the Siemens monoplane was broken, and now we are operating in this biplane room together with our interventional cardiology colleagues. Дәулет Шекович, ревьюда тұрған нені no деп алып тастайсаш? Все, спасибо. Рахмет. Okay, let's start. Yes, it's as usual manual injection. And okay. Женя, нужно будет переключиться на КТ. Ассаламу алейкум. Okay. На КТ можно будет переключиться. Okay, let's see this 3D. Okay. It's very important to have this option. Okay. We have challenge. We couldn't use coils because the artery coming from the dome of the aneurysm. This looks like here. Yes, you see? Yes, it's coming from the neck region, coming from here. I can use a couple of coils, but it would be, it still would be risk of choroid occlusion. But this segment is also quite short, this is artery. This is artery. Also there is a little bit stenotic segment. This part is 4 millimeter. This part is 425, maybe 4.5, 5 millimeter. And this part is nearly 3. And okay, it's not an easy, eh? Okay, because this artery is correcting all plan. Okay. It's not easy to place coil and not touch this choroidal artery. Huh? Okay, let's see MPR. Yes. Okay, this. No. Yes, it's coming something here. No? It's just from the neck of the aneurysm. Okay. It might be Evo, huh? Just a second. Let's check this. Yes, this is a choroidal artery. Just coming from the neck. Okay, all about the choroidal, and now we can check. Yes, very short IC. Very short IC. Okay, let's see what kind of instruments we have. It was look like PCOM segment, but it's a choroidal segment. Because okay. Headway 27, headway 27, 27, and fret X 4 on zigzag. Okay. Okay, let's place 4 millimeter fret. I think it will be better for in this clinical situation. Guys, bir second. Yes, it's coming from the dome, and it's a big risk of occlusion. Okay, I think epilateral is better. We'll take out all this stuff. No need for this. Okay, no coils. Maybe it's a web case, huh? Contour. Okay, sorry. Фен қосу керек. Patient already premedicated with ticagrelor, and I will ask Rowan to not give dual, only mono. And yes, it might be a problem. We need to see how the hemodialysis is influencing the level of ticagrelor. That's why I asked for the Fred X. It's coated with the X coating, anti-thrombogenic coating. But it's alive and there is no 100% guarantee. Okay. Status. Ильман, почитай, пожалуйста, как гемодиализ влияет на тикагрелор. На тикагрелор, да. Okay, we are using the heat gun. It's a fan 100 degrees for 10 seconds. Рахмет. Okay. Okay, we'll take this. Close it. Okay. Let's flush it. Yes, the plan could be changed during the operation, and it's a live condition. You can plan one and you can finish with another decision, which is better, should be better for the patient, but I'm not sure how much it would be better for the patient, because antiplatelet therapy is not so good, and the only option is yes, the microsurgical clipping is not so better. It would be a remnant part of the aneurysm, and also there is a stenosis and no general anesthesia. It's also challenging. Okay. And you have seen the tortuosity in proximal ICA. Okay. Now headway 27 is coming. Okay, let's do maximum zoom. And I think you noticed patient under local anesthesia. There is no intubation. Yes. Because of hemodialysis, there is a lot of correcting points. But without treatment, this aneurysm, I think, soon will rupture. Yes. This is the importance of 3D. Yes, if you do 3D, then your treatment is much more safer. And there is angulation. Okay. And as usual, the wire will go directly inside the aneurysm. Yes, I especially took the thread because it has flared ends, and the distal 2 millimeter to 3 millimeter is a stent. Then it's a flow diverter. Madina. Yes. Yes, it's a 3 millimeter proximal, 3 millimeter distal. It's a stent. We discussed with the chief of the microvention in 2017, and I asked to produce a thread with half FD and half stent. They can do 3 millimeter, but if they do 1 centimeter stent and then the rest is flow diverter, it's better. In such cases, you can start with stent and then continue with the flow diverter. Or in some cases like MCA bifurcation with lenticular stretors, you can start with flow diverter, then continue with stent. Yes, but they didn't do this improvement. We have only this. Okay. But I think there is a market for the stents like this, stent and then flow diverter. But nobody is ready to do this. Castrator. Okay, it's a 4 millimeter, and we should stop before the ophthalmic, or then we will need to place one more stent regular with a bigger diameter to prevent the step effect. Okay. As the navigation of the flow diverter inside the MCA, sometimes painful, but I hope now it will be okay. Yes. You can see the differences. There is a markers, and there is less metal, and then after 3 millimeter, maybe more, heparin 3000. 3000 unit of heparin. Yes, it will fall. It could fall down. That's why I'm starting from. Now it's fell down. Okay. As usual, it's tried to fall down. That's why we need to push the headway 27, and when it's pushed, then we can start to deploy. And the other point, A1 on the left side is hypoplastic. It's also not good for us. Yes, now stent is, flow diverter is coming, and distal part, the markers are not properly open. Maybe at the end they will open. But now we covered the aneurysmal part, and then our FD will finish in cavernous ICA. Okay. It's open maximum. Okay. Гепарин кетті ғой, да? Бізде картридж бітіп қалды ғой, да? Картридж бітіп қалды ғой. Okay. Maybe we need Kazakh thrombo test. Okay. On AP, the stent is started at the level of just below the carotid T. And now we need to check in different position. Okay. Okay. Do we need to push a little bit more? On AP not. On lateral, it's discussable. Eh? But the stent markers in M1 segment. Maybe we need to put something like credo to anchor the stent in M1 segment to prevent the fall down and opening the distal part. Let's see. We have no credo. We have no credo. Credo yok mu? Credo yok mu? Okay. Okay. Okay, there is no credo. Okay. We checked the data on hemodialysis and Berlinta, and there is no data on how it may influence on the effect of ticagrelor. Okay, it looks like we covered the segment, and yes, AP, I'm sure we covered, period. Because the markers in M1 segment, and now it's opening more. Yes, with other type of stents, it's possible to start just below the ICA, but this angulation is nearly 90 degrees, and usually it will fall inside the aneurysm. Yeah. That's why it's better to have different brands of material. Huh? It's so-called personification of the medicine. Now there is a stagnation. Okay. You can see the stagnation inside the aneurysm. Period, 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 period. There is stagnation. It's good. Okay. I will not wait too much. We open the fret. It's fully deployed, and now I need to cross with headway 27. We have only option. We have a solitaire 630 If it's needed, inside the thread through the 27 we can deploy the solitaire if there is something on distal market, but on lateral distal market is okay. On AP it looks like it's all concentrated, but lateral shows not. Yeah, it's open. And also 45 degree. Let's see. On 45, yes, the lateral is better. The markers are not in one place. And stent markers, we can see the thread is open with no problem. Okay. Now the lateral is better. Let's check it. Yes. We preserved open A1 segment. We didn't cover with the FD. It's good because this A1 is the main trunk. Yes, and stent just started below the carotid T. Okay. Okay, let's take a balloon. I will do massage. My microcatheter is inside. Yes, that's why it's quite safe. We can do angioplasty, the distal part, and if everything will be okay, then we can finish. Қай минутта стенд аштық қарайсыңшы? 27, да? Yes, it's 7 minutes after opening. Now let's take the... For stability, we need to place Chikai. Chikai is regular, it's not black. It's a regular Chikai. Келесі пациентқа келе берсін. Базиларный стеноз. As the next case, we are planning to do basilar stenosis and patient with multiple stenosis, and yes, I think it will be basilar stenosis. Yes. 620 balloon. It's a so-called shipping. Yes, balloon is arriving. Okay, let's place it in the balloon. Okay, now you can push the balloon. Okay. This is the proximal part. Yes, it's better to push something like hyperglide, but yes, we took a eclipse for possible balloon assistance, and now we have it. Okay, it's quite distal, then we can just pull it and push. I think it's touching the stent. Yes, with hyperglide is easier, but now we have no hyperglide on shelf. And let's see how the distal. Yes, distal is opened, and you can see the markers more open now. On lateral, it's really opened. Yes, it's a massage. Yes, now balloon is arriving. Okay, we're in distal ICA and MCA segment. Yes, usually it's better to do it under blank roadmap. Yes. I inflated, now I'm deflating. I oriented on the top image. Now we can take the balloon approximately. Yes, all stent is angioplasted. The proximal part is open. Oh. Yes, it's a very fast deflation. And balloon is 615, but the artery distal is 2 millimeter. Now it's 11 minutes after stent placement. I will take out my balloon. Yes, now the headways 27 is also outside. I think it's okay. It's 12 minutes after opening. That's the time of Kazakh thrombotest and test passed. Okay, I will take a little bit back my guiding. Our guiding. Let's do the angio. Oh. You can see slight stagnation inside the aneurysm, and now we can finish. Yes, the femoral is okay. The stent is started in MCA, but the flow diverter started in ICA. Дәулет Үлкеев минуспен көрсете саш, прямой боковойды. Үлкете саш? Картинкан. Okay. You can see on AP the stent is fully opposed to the wall of the artery, and on lateral it's nearly the same. Yes. Okay. Now we need to fix it and CT. Апа, қалайсыз?
Шүкір болады.
Жақсы? Болды, бітіріп жатырмыз. Қазір томография жасаймыз да, сонымен палатаға барасыз.
Ой, рахмет.
Жақсы, қорықпай жата беріңіз. Patient is okay. And now... Түк кететін бар ғой, да? Шовик. Все хорошо. Dear colleagues, SCP is ready. You can see the stent. And there is no complication and the brain is normal. Now we can finish this case, and patient is planned to go to the hemodialysis today. I hope the tachycardia in the circulation will be okay. Okay, let's see, like this. Yes, stent is opened. Okay. Thank you. See you in 25 minutes.